Good evening, Dr. Phil here. Today we'll be discussing on Mapleson breathing systems. Introduction. Mapleson did mathematical modeling of semi-open breathing systems available to him, and in 1954 he classified anesthetic breathing systems into A, B, C, D, and E. Mapleson F system is a Mapleson E system modified by Rees. Mapleson's assumptions when he performed his mathematical modeling of how each breathing system worked are as follows. Gases move and block and do not mix. Gases maintain their identity as fresh gas, dead space gas, and alveolar gas. The reservoir bag fills up continuously until it is full without providing any resistance to gas flow. The APL valve opens once the reservoir bag is fully filled, and the pressure within the breathing system exceeds the atmospheric pressure. The APL valve remains open during expiration, closes at the beginning of the next inspiration, and does not exert any resistance to gas flow. Components. The relative positions of the following three components determine how the breathing system was classified: the fresh gas flow inlet, APL valve, and gas reservoir, which may either be a reservoir bag or reservoir tubing or both. Corrugated tubing is used. It is kink resistant and connects the above-mentioned components. Efferent versus efferent reservoir systems. Limbs of the Mapleson breathing systems are named based on their position relative to the patient. The efferent limb carries gas towards the patient, and efferent limb carries gases away from the patient. Components such as the fresh gas flow inlet, APL valve, and gas reservoir may be on the efferent or efferent limb. Efferent reservoir systems. Examples include the Mapleson A, B, and C systems. The reservoir bag is situated on the efferent limb. These systems do not possess an efferent limb. The APL valve is located at the patient's end. An exception to this is the lag system. It is efficient during spontaneous ventilation, provided that the APL valve is separated from the fresh gas flow by more than the patient's tidal volume. It is not efficient during controlled ventilation. A fresh gas flow of more than 3 times the minute ventilation of the patient is required to prevent rebreathing of exhaled gases. Efferent reservoir systems. Examples include the Mapleson D, E, and F systems. These are derived from the airless T-piece. In order to prevent air entrainment, the T-piece requires a fresh gas flow of greater than the patient's peak inspiratory flow rate of 60 or more liters per minute if the system does not possess a reservoir. Thus, in order to reduce fresh gas flow requirements, a reservoir or tubing and/or a bag is situated on the expiratory limb. Efferent reservoir systems are efficient during controlled ventilation as long as the reservoir's volume exceeds the patient's tidal volume. Normal capnia is achieved with a fresh gas flow of about 0.7 times minute ventilation. Rebreathing almost always occurs, which is offset by increasing ventilatory rate. Efferent reservoir systems are not efficient during spontaneous ventilation and requires a fresh gas flow of 1.5 to 2 times the minute ventilation. Efficiency. Each system differs significantly in their efficiency during spontaneous or controlled ventilation as mentioned above. As semi-open systems, Mapleson systems rely on adequate fresh gas flow to wash out exhaled gases to prevent rebreathing. Order of efficiency. For spontaneous ventilation, from greatest to smallest, A, D, E, F, C, B. For controlled ventilation, from greatest to smallest, D, F, E, B, C, and A. Clinical uses. Mapleson systems are not used for anesthetic delivery to adult patients in the operation theatre, as expensive losses of anesthetic gases would incur if Mapleson systems were used, as they are less efficient than circle systems. Mapleson D and A are used in the anesthetic room only on rare occasions. Mapleson C is used for transferring or managing critically ill patients outside of the operation theatre. Mapleson F and E are used to ventilate pediatric patients. Advantages: Mapleson systems have simple design, they are cheap, they do not require CO2 absorbers, they are portable and light, and has specific advantages for ventilation of pediatric patients. However, Mapleson systems are inefficient when compared to the circle system. Mapleson A. The most commonly used version of the Mapleson A system is the Magil attachment. Components includes the fresh gas flow inlet. Fresh gas flow enters just proximal to the reservoir bag. Corrugated hose. An adequate length is a must, which usually ranges from 110 to 180 centimeters with an internal volume of at least 550 mL. The reservoir bag is located at the machine's end. The APL valve is located at the patient's end. This adds bulk at the patient's end and drags on the breathing circuit connection, particularly if it is connected to scavenging. Dead space. This consists of the volume of the anesthetic face mask and the angle piece to the APL valve. It measures about 100 mL if an adult mask is used. Pediatric face mask reduces dead space. Due to dead space, Mapleson A is not suitable for use in infants and children less than 4 years old or less than 25 to 30 kilograms. Spontaneous ventilation. Mapleson A is the most efficient system for spontaneous ventilation. The amount of fresh gas flow needed during spontaneous ventilation, if the system is functioning optimally with no leaks, fresh gas flow rate equal to the patient's alveolar minute ventilation is adequate to prevent rebreathing, which amounts to about 6 liters per minute for a 70 kg adult. Anesthetists typically use a higher fresh gas flow than minute ventilation to compensate for leaks. Mechanism of action during spontaneous ventilation. The 3 phases in the ventilatory cycle during spontaneous ventilation are the inspiratory phase, expiratory phase, and expiratory pause. During the inspiratory phase, fresh gas is inhaled from the system by the patient. The APL valve closes. During the expiratory phase, initial part, the pressure in the system does not increase as the reservoir bag is not full. Exhaled gases passes along the corrugated tubing towards the bag. The initial portion of the exhaled gas consists of dead space gas. The reservoir bag is also filled by fresh gas from the anesthetic machine. During the latter part of the expiratory phase, the reservoir bag becomes full, the pressure in the breathing system increases, and exhaled gas is vented to the atmosphere as the APL valve opens. During the expiratory pause, continued fresh gas flow pushes exhaled gas distally along the corrugated tubing, and these exhaled gases are vented out through the APL valve. No rebreathing takes place from the corrugated tube as long as the fresh gas flow rate is adequate to vent out all the exhaled alveolar gas through the APL valve prior to the next inspiration. If the fresh gas flow is more than or equal to minute ventilation, no rebreathing occurs. The volume of the corrugated tubing must exceed 1 tidal volume to ensure efficient spontaneous ventilation. Controlled ventilation. Mapleson A is one of the least efficient systems for controlled ventilation. During the expiratory phase, dead space and alveolar gas passes along the corrugated tube. These gases reaches the reservoir bag in most cases. The reservoir bag thus contains higher concentrations of CO2. During the inspiratory phase, inspiration is produced by squeezing of the reservoir bag. During the initial period, the APL valve does not open fully as the pressure generated in the system by compression of the reservoir bag is used to inflate the lungs. A higher APL valve opening pressure has to be set than that during spontaneous ventilation. Gases that reaches the patient's lungs includes alveolar gas, fresh gas, and dead space gas. The gas mixture is vented out to the atmosphere when the APL valve opens during the latter part of inspiration. The fresh gas flow rate must be very high, 3 times or more the alveolar minute ventilation to prevent rebreathing. The gas volume delivered from squeezing the reservoir bag must be large enough to inflate the lungs and vent gas from the system out through the APL valve. At the end of inspiration, the bag is typically less than half full. The lag system. This is a modification of the Mapleson A system. It is designed to overcome the disadvantages of the Magil attachment. The Magil attachment is heavy and cumbersome as the APL valve is attached close to the mask. Its weight increases at the patient's end, especially if a scavenging system is used. The bulky APL valve is obtrusive, especially during head and neck surgery. Components of the lag system. It consists of a coaxial arrangement of tubing. The coaxial tubing refers to a tube inside a tube structure, and it is 1.8 meters in length. The outer tube is 30 millimeters in diameter, and the inner tube is 14 millimeters in diameter. The inner tube must possess an adequately large internal diameter to allow the patient to exhale with minimal resistance. The APL valve is positioned at the proximal end of the system to avoid adding bulk at the patient's end. The reservoir bag is located at the machine's end. It has similar characteristics to the Magil system. It is efficient for spontaneous ventilation. Fresh gas flow of 70 ml per kg per minute is sufficient to prevent rebreathing. It is in fact more efficient than the Magil system in certain studies. However, the lag system is inefficient for controlled ventilation. Advantages. It is efficient for spontaneous ventilation and bulky components are all at the machine's end. Disadvantages. It is inefficient for controlled ventilation as mentioned. If there is a leak from the inner tube, hypercapnia occurs from CO2 buildup as the entire system becomes dead space. A parallel lag circuit exists with separate inspiratory and expiratory limbs. This system has similar characteristics to the coaxial version, and its design avoids the previously mentioned issue with a leaking inner tube. Mapleson B. The fresh gas flow inlet and the APL valve are at the patient's end of the tubing. Complete mixing of alveolar and fresh gas occurs during spontaneous and controlled ventilation, thus it is very inefficient. It requires a very high fresh gas flow, 2 to 3 times minute ventilation to prevent rebreathing, which equates to about 15 liters per minute for an adult. Compared with Mapleson A, Mapleson B is markedly more inefficient for spontaneous ventilation, but it is slightly more efficient for controlled ventilation. Mapleson B systems has no clinical role. Mapleson C systems. It is similar to a Mapleson B system but does not possess a reservoir tubing. The following are positioned at the patient's end: the bag, fresh gas flow inlet, and the APL valve. During spontaneous or controlled ventilation, mixing of alveolar and fresh gas occurs. It is thus very inefficient and requires a very high fresh gas flow rate of 2 to 3 times minute ventilation to prevent rebreathing. Sometimes it is used to ventilate patients during transport or during resuscitation as an alternative to a self-inflating bag such as an ambu bag. Volatile anesthetics are not used, and efficiency is less important than portability in these situations. However, a design with a self-inflating bag and non-rebreathing valve is preferred, such as an ambu bag. The Waters system. Also known as the to and fro system, the Waters system has been replaced by the circle system on most anesthetic machines. Mechanism of action. The Waters system is a Mapleson C breathing system with a soda lime canister interposed between the APL valve and the reservoir bag. It has many disadvantages. The dead space of the system increases as the soda lime granules nearest to the patient becomes exhausted progressively. Unless the soda lime is packed tightly in its canister, gases may be channeled above the soda lime as the canister is horizontally positioned. There is risk of the patient inhaling soda lime dust from the canister. A filter is positioned in the canister to prevent soda lime from entering the breathing system to minimize this problem. The water system is cumbersome. Advantages of the Mapleson C system: it is simple and lightweight and useful for resuscitation. PEEP can be applied, and the bag gives a visual and tactile indication for ventilation. Disadvantages: it is inefficient, CO2 accumulates over time, the APL valve is bulky and adds weight to the patient's end, and requires a pressurized gas supply. Mapleson D system. Components includes a fresh gas flow inlet. Fresh gas flow enters the patient's end. The APL valve is located at the machine's end. The reservoir bag is mounted on the machine's end, and the corrugated tubing is 1 meter in length. Spontaneous ventilation. The Mapleson D system is inefficient during spontaneous ventilation. During the expiratory phase, exhaled gases and fresh gas mix in the corrugated tube. Dead space gas followed by exhaled gas and fresh gas travel towards the reservoir bag. The spill valve opens when the reservoir bag is full and the pressure in the breathing system increases. The mixture of fresh gas, dead space gas and exhaled gas is vented out the APL valve. During the expiratory pause, fresh gas pushes alveolar gas towards and out of the APL valve. During the inspiratory phase, fresh gas flow rate of 2 times or more the alveolar minute ventilation, up to 250 mL per kg per minute in an adult, is required to prevent rebreathing. If fresh gas flow is inadequate, a mixture of alveolar and fresh gases is inhaled from the corrugated tube. Controlled ventilation. The Mapleson D system is efficient during controlled ventilation. Efficiency during controlled ventilation is improved when an expiratory pause is included in the ventilatory cycle. During the expiratory phase, corrugated tubing and reservoir bag fill with a mixture of fresh and alveolar gas. During the expiratory pause, fresh gas fills the distal part of the corrugated tube. During the inspiratory phase, it is initiated when the reservoir bag is squeezed. Fresh gas enters the lungs, APL valve opens and fresh gas and alveolar gas is vented out. The fresh gas flow rate should always be more than the patient's minute volume to avoid rebreathing. The Bain coaxial system. This is the most commonly used version of the Mapleson D system. The coaxial tubing arrangement. The typical length of the tube is 180 centimeters. It can be 270 centimeters for dental or eye surgery and up to 540 centimeters for MRI scans. Increasing the length of the tube does not affect the respiratory mechanics of the breathing system. Fresh gas flows down a narrow 6 mm inner tube. The swivel mount at the patient's end ensures that the inner tube is kink resistant. If the inner tube kinks, fresh gas will not be delivered to the patient. If the internal tube is disconnected at the machine's end, a large increase in dead space occurs, resulting in hypoxemia and hypercapnia. Exhaled gases passes down the 22 mm outer tube. This system has a reverse arrangement to the coaxial Mapleson A system. A parallel version exists. The reservoir bag and the APL valve is mounted at the patient's end. Movement of the reservoir bag during spontaneous breathing does not guarantee that fresh gas is being delivered to the patient. To check that there are no leaks in the system for components other than the inner tube, connect all the components, connect the proximal end to the common gas outlet, inspect the outer tube for breakage, set the fresh gas flow rate to 5 liters per minute, close the APL valve fully, occlude the outer tube at the patient's end and ensure that the reservoir bag fills, and then turn off the flow meter and ensure that the reservoir bag does not collapse. Check that the APL valve functions normally and check for defects or blockage of the angle piece and filter. To check that the narrow inner tube is functioning normally, this tube should be tested by occluding its distal end with a finger or plunger of a small syringe while setting the fresh gas flow at 5 liters per minute. If the inner tube is not leaking or disconnected, there would be a descent in the flow meter bobbin during occlusion and an audible release of pressure when the occlusion is discontinued. If this tube is obstructed, disconnected or leaking, hypoxemia and hypercapnia may occur. Spontaneous ventilation. The Bain system is inefficient during spontaneous ventilation. During inspiration, fresh gas flow from the inner tubing is supplemented by gases from the outer tubing. During expiration, exhaled gases passes back down the outer tubing to reach the bag. Exhaled gases mix with fresh gas. This mixture continues until the bag is full and APL valve opens to allow for venting. During the expiratory pause, mixed gas from the tubing and bag is used for the next inspiration. A fresh gas flow rate of 1.5 to 2 times alveolar minute volume is sufficient to prevent rebreathing to an acceptable level. Thus, a fresh gas flow of 150 to 200 mL per kg per minute is required. To prevent rebreathing completely, a fresh gas flow of 3 times the patient's minute volume is required. Use of the Bain system with a mechanical ventilator during controlled ventilation. The Bain system is efficient during controlled ventilation. An example of a mechanical ventilator that can be used with the Bain system is the Penlon Nuffield 200. In this setup, the bag is replaced by the ventilator. The APL valve must be completely closed. The system functions as a T-piece. The corrugated tubing is 1 meter in length. Its volume must be more than 500 mL to avoid having the driving gas from the ventilator entering the breathing system. During the inspiratory phase, anesthetic gases are supplied to the Bain system. The patient inspires fresh gas from the outer tube. After setting the tidal volume and respiratory rate, the ventilator pushes anesthetic and alveolar gases from the corrugated tube into the patient's lungs. During the expiratory pause, fresh gas washes expired gases from the outer reservoir tubing. During the expiratory phase, expired gases is mixed with fresh gas. The ventilator gas and a portion of the alveolar gas are vented through the exhaust valve of the ventilator. To adjust the degree of rebreathing, this is achieved by adjusting the anesthetic gas flow rate. For normal capnia, this is achieved by setting the gas flow rate at 70 to 80 mL per kg per minute. To achieve moderate hypocapnia, set the gas flow rate at 100 mL per kg per minute. Some rebreathing typically occurs. By increasing the respiratory rate, a fresh gas flow rate of 0.7 minute volume can be used to reduce rebreathing to acceptable levels. Consequences of gas leakage. If the connection between the Bain system and the anesthetic machine is not secured, a leak of fresh gas causes rebreathing of ventilator gas, and this results in awareness, hypoxemia, and hypercapnia. Advantages of the Bain system. It is efficient for controlled ventilation. It is compact. The bulky components are at the machine's end and not the patient's end. Scavenging can be done. It has low dead space. The APL valve is at the machine's end. The Bain system can be used with a mechanical ventilator. Disadvantages. It is inefficient for spontaneous ventilation. The entire system becomes dead space if the inner tube becomes disconnected or is leaking. Mapleson E. Also known as Ayres T-piece, components include a T-shaped rigid tube which has connections to the fresh gas flow inlet, patient mask or tracheal tube, and a variable length of reservoir tubing. Advantages. It has almost no resistance to expiration as it is valveless and bagless. It has minimal dead space. Since there are no valves, high pressures induced by valve failures are avoided. It is used extensively in pediatric anesthesia for children up to 25 kg, but has been superseded in clinical use by the Mapleson F system. Disadvantages. PEEP or CPAP cannot be applied. For patients less than 6 years old, they have low functional residual capacity, and CPAP is beneficial in increasing FRC. Intermittent positive pressure ventilation is difficult to apply and potentially hazardous. Scavenging is difficult since there is no APL valve. The Mapleson E system functions similarly to the Mapleson D system. During spontaneous ventilation, it is inefficient. During the inspiratory phase, fresh gas is drawn from the reservoir and from the fresh gas flow. Rebreathing is prevented by providing a fresh gas flow rate of 2.5 to 3 times the patient's minute volume. A fresh gas flow rate of 4 liters per minute or more is recommended for a pediatric Mapleson E system. During the expiratory phase, exhaled gas is vented down the reservoir tubing. The corrugated tube fills with a mixture of exhaled and fresh gas. During the expiratory pause, the corrugated tube fills with fresh gas. The volume of the reservoir tubing, if it is too large, rebreathing may occur. If it is too small, air may be entrained. The volume of the corrugated tubing must be more than the patient's tidal volume to prevent rebreathing. Visual indicator for spontaneous ventilation. Since there is no reservoir bag, there is no indication for the presence or adequacy of spontaneous ventilation. A piece of tissue paper or feather attached to the end of the corrugated tube can be used as a visual indicator for spontaneous ventilation. Controlled ventilation. IPPV can be delivered by occluding the end of the corrugated tube with a finger. However, there is a high risk for barotrauma as there is no way to assess the pressure in the system. Mapleson F. Also known as the Jackson-Rees modification of the RST piece, an open-ended bag is attached to the end of the corrugated tube. Advantages. As for Mapleson E, it has almost no resistance to expiration, has minimal dead space. Since there are no valves, valve failure-induced high pressures are avoided. It is the standard breathing system for pediatric patients. The upper limit is around 20 to 30 kg depending on the author. An alternative would be a small caliber circle system. The volume of the tubing depends on its length, but it's usually 200 ml. The volume of the bag is typically 500 ml. The bag provides visual evidence of spontaneous breathing. The bag can be used to confirm if there is fresh gas entering the breathing system by occluding the open end of the bag temporarily. Partial occlusion of the open end of the bag provides CPAP during spontaneous ventilation and positive end expiratory pressure during IPPV. The bag can be used to provide controlled ventilation, with the 4th and 5th fingers used to occlude the open end of the reservoir bag, and the thumb and index fingers used to squeeze the bag. Relax the occlusion during expiration to allow gas to escape from the bag. The inflation pressure and lung or chest wall compliance can be roughly gauged by finger pressure. IPPV can also be provided by replacing the bag with a ventilator such as the Penlon Nuffield 200. The Mapleson F system is more suitable for inhalational induction than a circle system for pediatric patients. An APL valve can be added right before a closed-ended 500 ml reservoir bag. To allow for scavenging, the APL valve is actuated at 30 cm H2O. Disadvantages of the Mapleson F system. Scavenging is not standard and not efficient. It is inefficient. Fresh gas flow of 2 to 3 times the minute volume is required to prevent rebreathing. Skill is required for its use. Partially occluding the tail while squeezing the bag at the same time requires practice. If there is a tear in the bag, the anesthetist would not be able to pressurize the bag or establish IPPV. A high fresh gas flow is needed to compensate for the leak. Circuit check should be performed to detect such leakage and obstruction. Check whether the tubings are patent. Check for foreign bodies and remove them. Check the bag tail is patent. Fill the circuit with fresh gas while occluding the patient connection and the bag tail, and check if the circuit can be pressurized and examine for leaks. Management of a tear in the bag. If the tear is discovered during spontaneous breathing, increase fresh gas flow rate and replace the bag with a new bag. If the tear is discovered during controlled ventilation, remove the bag and attach the reservoir tubing to a ventilator. ADE system. This system is designed by David Humphrey in 1983. Advantages. It can be used for spontaneous or controlled ventilation in adults or children. It provides the advantages of the Mapleson A, D, and E systems and allows quick and easy switching between these systems without the need for disconnection from fresh gas flow or change of breathing tubings. This is achieved by switching the lever on the block either upwards or downwards. The Humphrey ADE block respiratory mechanics are more efficient than conventional Mapleson systems. For example, To prevent rebreathing, a fresh gas flow of 70 mL per kg per minute is required for a conventional Mapleson A system, but only 50 mL per kg per minute for a Humphrey ADE block in Mapleson A configuration. The smooth inner bore 15 mm tubing has low turbulence and resistance to breathing. The resistance to breathing is similar to a 22 mm corrugated tubing of equal length. This tubing can be used for both adults and children. Corrugations are located externally to prevent kinking. Disadvantages: it is not intuitive to use, and the heavy block risks easy dislodgement from the common gas outlet. Components: 2 parallel lengths of 15 mm smooth bore tubing. One delivers fresh gas flow, and the other carries exhaled gas. The connection can be made, for example, to the common gas outlet of an anesthetic machine to supply the fresh gas flow. The Y connection connects the distal end of the parallel tubings to the patient. The Humphrey block connects to the proximal end of the parallel tubings. It is mounted on the anesthetic machine. Connections are labeled. It consists of the APL valve. It has a visible indicator of valve performance, a lever to select spontaneous or controlled ventilation, a reservoir back mount, a port to connect to a ventilator, connections to the inspiratory and expiratory limbs of a breathing system, a safety pressure relief valve which opens at a pressure of above 6 kPa or 60 cm H2O. New designs incorporates a soda-lime canister. Mechanism of action of the Humphrey ADE block. The Humphrey ADE block achieves easy transition between the Mapleson A, D, and E systems by altering the positions of the reservoir bag and APL valve relative to the patient. In the Mapleson A system, fresh gas flow is in the efferent limb, reservoir bag or ventilator is in the efferent limb, and APL valve is in the efferent limb, and it is used during spontaneous ventilation in adults. For the Mapleson D system, the fresh gas flow is at the efferent limb, reservoir bag or ventilator is at the efferent limb, and APL valve is at the efferent limb, and the Mapleson D is used during controlled ventilation in adults. For the Mapleson E, the fresh gas flow is at the efferent limb, there is no reservoir bag or ventilator and no APL valve, and it is used during ventilation of children. By adding ports to the efferent and efferent limbs of the breathing system, a rotatory lever is able to isolate one or both ports and the APL valve to switch between Mapleson A, D, or E. At port 1, the reservoir bag is attached. At port 2, it is either left open to the atmosphere or attached to a ventilator. This schematic is simplified, and the inner workings of the Humphrey ADE block are far more complex. A mode: when the lever is turned up, the Humphrey ADE block acts as a Mapleson A system. The port 2 is disconnected from the system. Fresh gas flow and APL valve remains connected. The reservoir bag is connected to the breathing system via port 1, and back ventilation is possible. The inspiratory limb is the breathing hose that connects the bag to the patient. The other tubing carries exhaled gases to the APL valve. The APL valve is connected to the scavenging system. The APL valve offers a PEEP of 1 cm H2O when opened fully, which improves the FRC of pediatric patients. The fresh gas flow required to prevent rebreathing is 50 mL per kg per minute. DE mode: when the lever is turned down, port 1 and the APL valve are disconnected from the system. Port 2 remains connected. It acts as a Mapleson E system if port 2 is left open to the atmosphere. It acts as a Mapleson D system if port 2 is connected to a ventilator. However, this is not strictly a Mapleson D system as the APL valve is redundant. The expiratory limb of the A mode becomes the inspiratory limb, which delivers gas to the patient. The other tubing that carries exhaled gases to the APL valve in A mode becomes a reservoir to the T-piece. Appropriate fresh gas flow rate: for spontaneous ventilation for adults, 50 to 60 mL per kg per minute. For children less than 25 kilograms, the initial fresh gas flow should be 3 liters per minute to provide a margin of safety. During controlled ventilation for adults, the fresh gas flow rate should be 70 mL per kg per minute. For children less than 25 kilograms, the initial fresh gas flow should be 3 liters per minute and adjust fresh gas flow to maintain normal carbia. These are my references. Thank you.